Welcome to the Deep Dive, your shortcut to being genuinely well-informed. Today, we're tackling a topic that, well, it strikes fear into the heart of every horse owner, colic. But we're not just grazing the surface. Our deep dive today is into one of the most critical, common, and potentially life-threatening forms, equine large colon displacements. Our mission, as always, is to sift through the complex information, pull out the most vital insights, and deliver them to you, maybe with a few surprising facts and just enough humor to keep you hooked.
That's right. These are conditions where the large bowel, inside the horse's abdomen ends up in an abnormal position. This often means a blockage, and critically, sometimes the blood supply to that section of the gut gets cut off. That poses an immediate and severe threat to the horse's life.
And here's where it gets truly fascinating. It all starts with some pretty unique anatomical quirks, doesn't it? The horse's large colon is surprisingly mobile, and it has these, abrupt changes in diameter. These are primary reasons it gets into trouble.
Okay, I'll
It's badass.
Yeah, to really grasp why these displacements are such a problem, you have to appreciate the sheer scale of the equine gastrointestinal, or GI, tract. Imagine this. An adult horse, maybe 500 kilos, has a digestive system about 30 meters long. 30 meters. With a total volume of roughly 180 liters.
Wow, 180 liters, that's huge.
It really is. It's like fitting a garden hose the length of a tennis court and filling almost 2 full bathtubs inside a horse. And the large intestine alone accounts for 40 to 50% of that massive capacity. It acts as the hindgut, for crucial microbial fermentation. Now, here's the profound insight. Despite their powerful physique, a horse's internal architecture is surprisingly, precarious. This huge, large colon has very limited fixation within the abdominal cavity. It's really only anchored at 2 main points, where the right dorsal and transverse colon meet, and then to the cecum, that giant fermentation vat via something called the cecocolic fold. This minimal attachment allows the majority of this extensive, often gas-filled organ to just move freely. Makes it incredibly susceptible to abnormal positioning.
Right. And speaking of critical points, we need to highlight the pelvic flexure. Think of this as a narrow, horseshoe-shaped U-bend connecting the left ventral and left dorsal colon. It sounds important.
Oh, it is. Its significance is huge because that abrupt decrease in diameter makes it a common bottleneck, a prime spot for impactions, basically. Plus, it functions as a kind of internal pacemaker, coordinating the contractions that regulate how digested material moves through the hindgut.
So it's a weak spot and a control point, all in one.
Exactly. And beyond the anatomy, several physiological factors can contribute to these displacements. First, there's excessive gas accumulation, often called tympany. When a horse has too much gas from fermentation, maybe from sudden diet changes, big meals of fermentable feeds, or even altered gut bacteria, this gas increases the colon's buoyancy.
Buoyancy, like it floats.
It literally allows the colon to float out of position, like a balloon escaping your hand. Then there's motility dysfunction. Abnormalities in those coordinated contractions, especially from that pelvic flexure pacemaker region, can lead to food just sitting there too long. That causes retention of digesta and, impactions. Dietary changes are another big one. High-grain diets can alter colonic contents, increase risk. And of course, poor quality roughage or not enough water can lead to dry, stubborn impactions. We also see a predisposition in mares who've recently foaled, postpartum mares, to a specific type of twist called a volvulus.
Why is that? More space inside.
Exactly. The increased abdominal space after foaling allows for greater colon movement. And even just having a foal at foot is an additional risk factor for these mares. Finally, some horses simply have a naturally deeper anatomical space near their spleen and kidney, the nephrosplenic space. Unfortunately, that can contribute to recurrence of specific entrapments.
It's not just what's happening deep inside the gut. Sometimes, surprisingly, the problem starts way further up, with something as simple as how a horse chews its food. Here's something many people don't realize. Poor dentition. Insufficient chewing. If a horse can't properly grind its feed, larger, undigested particles reach the hindgut, causing impactions. And we know impactions are a risk factor for displacement.
That's a really crucial point.
It really underscores the need for a holistic approach, doesn't it? Integrating routine preventative dental care into the overall strategy. It's a powerful reminder that seemingly small details can have major impacts. Okay, so given this incredible mobility and these predisposing factors, maybe it's no surprise there are several distinct ways a colon can get into trouble. What are the most common scenarios you see? What makes each one unique?
Well, the large colon can misposition itself in a few key ways. One common one is left dorsal displacement, often called nephrosplenic entrapment. This is essentially where a section of the left large colon gets caught, entrapped between the body wall and the spleen. It gets held in place by a fibrous band connecting the spleen to the left kidney, the nephrosplenic ligament.
So it's like a hammock where the colon gets stuck. That sounds awkward.
It is. What happens inside is that this left colon actually shifts upwards and can even twist around, sometimes a full 180 degrees. There's a more severe form, type 2, where the very front parts of the colon migrate, which can make it tricky for a vet trying to pass a stomach tube. Now, this type is typically non-strangulating, meaning the blood supply isn't immediately cut off. But if it lasts more than about 24 hours, it can still cause significant colonic congestion, swelling, or even damage to the gut wall. And rarely, a more severe twist of volvulus can occur right there at the entrapment site, which would definitely compromise blood supply.
Okay, so that's the left side. What about the right?
Then we have right dorsal displacement, or RDDLC. Here, the pelvic flexure that you bend we talked about migrates and ends up stuck between the cecum and the horse's right abdominal wall. For surgeons, the direction it goes matters for correction, but for you, the key is that this displacement causes a painful kinking and blockage, often found up towards the front of the abdomen. Like LDDLC, it's usually non-strangulating, but a deeper twist at the base of the colon can, again, compromise blood flow.
Now, large colon volvulus, or torsion, that just sounds much more serious, is it?
It definitely can be, yes. This is a true twisting of the large colon on itself. Usually involves the mesentery, that sheet of tissue connecting the ventral and dorsal parts of the colon. The most common starting point is at the junction between the right ventral colon and the cecum.
Like kinking a hose completely.
Exactly. Imagine a garden hose twisting around itself and cutting off the water flow. That's basically what's happening to the blood supply.
So it's a strangulating obstruction then. That's the dangerous one.
Precisely. The severity depends directly on how much it twists. A less severe twist, say under 270 degrees, might only cause an obstruction. But anything greater than 360 degrees leads to a strangulating obstruction, rapidly cutting off blood supply. Without immediate intervention, this quickly becomes fatal. The key predisposing factor here is often disproportionate gas accumulation. We see it a lot in those postpartum mares, with the empty space.
Right, you mentioned them.
Or in horses on lush grass, or eating highly fermentable feeds. Lots of gas.
And finally, what about retroflexion of the pelvic flexure? Is that common?
That's where that U-bend, the pelvic flexure, gets positioned unusually, kind of forward towards the diaphragm. Its naturally narrow shape makes it a common site for impactions anyway. What's fascinating here is the common thread, the recurring theme across nearly all these types. It's gas distension. It really underscores the fundamental importance of managing the horse's diet and promoting a stable, healthy hindgut environment. That's crucial prevention. Anything that promotes excessive fermentation or gas production significantly increases the risk of the colon literally floating or twisting out of place.
Given how quickly these conditions can escalate, accurate and timely recognition of the signs is absolutely paramount for any horse owner. You know your horse best, so changes, even subtle ones, they really matter. The primary sign, the most consistent one, is abdominal pain. Colic. You'll see horses pawing, looking at their flank, kicking at their belly, lying down, maybe rolling. Sometimes they'll sweat, strain to defecate, or do that Fleeman response, curling the upper lip. Pain can range from mild to really severe. Onset is often sudden, but sometimes you might see intermittent discomfort first. You might also notice their belly looks distended, or they're just not pooping much or at all.
And physiologically, while heart rate and respiratory rate might start normal, they will increase as pain escalates, or if toxins get into the bloodstream, that's endotoxemia.
Endotoxemia, that sounds bad.
It's very bad. A severe, full-body inflammatory response. Triggered by toxins from bacteria in the compromised gut, it can lead to shock, organ failure, serious stuff. Their gums, the mucous membranes, can change from healthy pink to pale or even purple. And their capillary refill time, you press on the gum, see how quickly the pink returns might be prolonged. That shows poor circulation. Lethargy, not eating. Those are common too. Now, gastric reflux, fluid backing up in the stomach, it's inconsistent, but it can happen. Particularly in RDDLC if the colon blocks the small intestine outflow, or in LDDLC maybe up to 43% of cases. Sometimes, in a specific type of LDDLC type 2, it can even be hard to pass a nasogastric tube. And interestingly, with LDDLC, the horse's heart rate is often less high than you'd expect for the amount of pain they seem to be in.
So what's the practical takeaway here for a horse owner watching their horse? What's the big red flag?
How the horse responds to pain medication? That's a critical diagnostic indicator. Mild pain might ease up with standard treatment, but persistent, unrelenting pain despite analgesia, That often signals a surgical emergency. It's a huge red flag that something serious is going on inside. Don't wait.
Okay, so pain response is key. What about what the vet finds?
Well, rectal palpation, feeling inside, while it can be tough with a big or gassy horse, is indispensable for a veterinarian. For left dorsal displacement, a vet might feel a tight band over that nephrosplenic ligament. The spleen itself might feel pushed medially, the colon on the left might feel wrong, or its bands could be going in an odd direction, craniodorsally. Rectal palpation can actually confirm the diagnosis in a good chunk of cases, maybe 60–70%.
That's pretty high.
It is. With right dorsal displacement, the key findings are usually the absence of the pelvic flexure in its normal spot back into the left. The large colon might be felt beside the cecum, or its bands might be running across horizontally in the back of the abdomen. You might feel gas or an impaction in the large colon, and the cecum could be distended or even hard to find. For retroflexion, the back of the abdomen might feel surprisingly empty because the pelvic flexures move forward. And in a large colon volvulus, often it's just massively gas-distended colon everywhere, making deep palpation really difficult, almost impossible sometimes.
But you said rectal exam isn't foolproof, right? About 20% false positives.
Exactly. It's important to remember that. Other things like a cecal impaction, simple gas colic, or even enteroliths, those gut stones can feel similar sometimes, which really just underscores the need for a multimodal diagnostic approach. You need to put all the pieces together.
Use all the tools in the toolbox.
Precisely. Other initial steps often include passing that nasogastric tube, helps relieve pressure, checks for significant reflux, like more than 2 liters every couple of hours, and listening to the gut. Abdominal auscultation. Usually sounds are decreased or absent, though sometimes very early in strangulating lesions, they might actually be increased briefly. You might also hear characteristic pinging sounds if you flick the abdomen, indicating gas.
So when those initial checks don't give a clear answer or the horse is really sick, that's when the advanced tools become essential. Abdominal ultrasound sounds like a game changer here.
It really is. It's rapid, it's non-invasive, and gives immediate visual info. You can see where things are, wall thickness, motility, what's inside, any extra fluid. For left dorsal displacement, the vet might see gas shadowing the spleen, or the spleen pushed down, or the colon literally sitting next to the spleen where it shouldn't be. It's pretty sensitive, detects it about 89% of the time, though you can get false results sometimes.
And for the other types?
For right dorsal displacement, it's a bit less sensitive, maybe 56–67%. But a vet can often make a presumptive diagnosis by seeing abnormally positioned colonic blood vessels against the right body wall between the ribs. For a large colon volvulus, the big clues are hugely distended colonic vessels running lengthwise and significantly thickened intestinal walls, sometimes up to 10 millimeters thick, when normally they're much thinner, less than 5 millimeter. Beyond just finding the displacement, ultrasound is invaluable for distinguishing between non-strangulating and strangulating lesions. That's the critical difference.
Life or death difference, really.
Absolutely. Distended, non-moving loops of gut, increased free fluid in the abdomen, thickened, abnormal-looking loops. They all scream strangulation, the main limitations. Well, image quality can be tricky in overweight or dehydrated horses, and lots of gas inside can block the view of deeper structures.
Now, you mentioned X-rays, abdominal radiography. Limited for adults, you said.
Yeah, for large colon displacements in adults, it's limited by the horse's size and all the gas. But it's still really useful for detecting enteroliths, those gut stones, with very high accuracy. Also good for sand colic, finding metal objects, and just seeing generalized gas buildup.
Okay, what about CT scans? Computed tomography. That sounds high-tech.
It is, and it offers revolutionary potential. While scanning the entire abdomen of an adult horse isn't routine everywhere yet, big advancements in large CT units are making whole-body imaging possible, especially useful for things like enteroliths.
How so? Better than X-ray.
Oh, yeah. CT excels at pinpointing the exact location, size, and number of enteroliths. But here's where it gets really interesting for displacements. CT can identify them, even ones that shift with gravity, by imaging the horse lying on its belly and its back. This gives the surgeon incredibly precise information before surgery, which can really shorten the time needed for exploration once they're inside.
That sounds like a huge advantage.
It is, and the development of standing CT systems is exciting too, more accessible, lower cost, and avoids the risks of general anesthesia. Huge potential there.
Good point about anesthesia risks.
Oh, and just to avoid confusion, you might hear CT used for something else in equine medicine. Closure time in platelet function analysis. That's a blood test for clotting, totally different from the computed tomography imaging we're talking about.
Got it. 2 different CTs. And finally, peritoneal fluid analysis. tapping the belly fluid.
Yes, taking a sample of the fluid from the horse's abdomen, it's a key diagnostic step. Incredibly valuable for helping vets differentiate strangulating versus non-strangulating obstructions. And as we've said, that dictates the immediate need for surgery.
What are they looking for in the fluid?
Vets analyze key markers, like lactate levels compared to protein levels, and compare fluid lactate to blood lactate. They also check inflammatory markers like IL-6. While the specific ratios and numbers are complex, the bottom line for you is that these tests provide crucial physiological clues about how severe things are and whether a part of the gut is dying from lack of blood flow. Of course, these results are always interpreted alongside all the clinical signs and how the horse is responding to initial treatment. It's never just one test.
Right, the whole picture. So, okay, a horse is diagnosed. What are the treatment options? It sounds like it ranges quite a bit.
It really does. Management can range dramatically from conservative medical approaches to complex surgical interventions. It's a spectrum, and the path depends entirely on the horse's specific situation, the type of displacement, if blood supply is cut off, how sick the horse is.
Let's start with medical management. When is that used?
For non-strangulating displacements and also for impactions, medical management is often the first line of defense. General principles include pulling feed for anywhere from 12 to 72 hours. Giving intravenous fluids, full V fluid, is crucial to correct dehydration and help hydrate any impacted manure. Pain management using things like flunixin, which is an NSAI, or maybe opioids like butorphanol, sometimes low-dose sedatives, and administering laxatives or lubricants like mineral oil or maybe psyllium through a tube into the stomach.
Does exercise help? I've heard that sometimes.
Yes, light exercise can play a role. Simply jogging for 10 or 20 minutes or hand walking can stimulate GI motility and help the gut sort of reset itself. For left dorsal displacement specifically, circling the horse on the left rein can be beneficial. It might increase the space between the spleen and the body wall, helping the colon slide back where it belongs. But, and this is vital, rolling needs to be controlled. Letting a colicky horse roll violently can actually turn a non-strangulating displacement to a much more dangerous strangulating one.
Good point. So no uncontrolled rolling.
Definitely not. For LDDLC specifically, vets might try a medication called phenylephrine intravenously. It makes the spleen contract, shrink temporarily, which can create space for the colon to move back. It's often followed by that light exercise. However, it's used with extreme caution, especially in horses over 15, because there's a rare but serious risk of it causing a fatal bleed from a large blood vessel.
Wow. Okay. So careful use there. What if that doesn't work?
If phenylephrine and exercise fail for LDDLC, another technique is a controlled roll under general anesthesia. The horse is put under, positioned on its right side, then carefully rolled over its back onto its back, maybe lifting the hind legs and then onto its left side. The vet then checks with palpation or ultrasound to see if it worked. And in cases with basically yes, carefully puncturing the distended bowel, like the cecum or large colon, through the skin to let the gas out. It can improve blood flow, create space, but it does carry a small risk of leakage. Beyond these, for more complicated situations, we might use prokinetics drugs to stimulate gut movement, maybe after surgery if things are slow to start up again. And for severe cases, especially with volvulus where those toxins are a big issue, anti-endotoxic therapies are crucial. Various treatments aimed at fighting that systemic inflammation and preventing shock.
Okay, so that's medical. But sometimes surgery is unavoidable, right?
Absolutely. If medical management fails, or if the condition is severe from the start, like a suspected strangulation, then surgical correction is necessary. The standard approach is an exploratory laparotomy. Basically, opening the abdomen through an incision on the belly, the ventral midline, under general anesthesia. The goals are clear. Find the problem, manually fix the displacement or twist, check if the bowel tissue is still viable, and sort out any issues, empty impactions, release gas, untwist it, or even remove damaged sections.
It sounds like major surgery. But you mentioned advancements, less invasive options.
Yes. What's truly exciting is the shift towards less invasive, more targeted techniques in some cases. One example is standing laparoscopy. Keyhole surgery, basically. This allows vets to fix certain displacements, like nephrosplenic entrapment, while the horse is standing and just sedated.
While it's standing, wow.
Yeah, it dramatically reduces the risks and costs of general anesthesia and often means a faster recovery. It's also used for preventative prophylactic procedures. Another proactive shift is something called colopexy. This is a preventative surgery where a part of the large colon is attached to the abdominal wall to stop it from displacing or twisting again in the future.
So that's done preventatively.
It can be, yeah. Usually in horses with recurrent problems. It shows a sophisticated, proactive approach, though it's not something routinely recommended for every horse. It has potential downsides, too. And then if a section of the colon isn't viable, if the blood supply was cut off for too long, or sometimes for mares with repeated large colon volvulus, a more extensive surgery is needed. Colon resection and anastomosis. That means removing the damaged section and sewing the healthy ends back together. A major undertaking.
And after the surgery, the care doesn't stop there, I imagine.
Not at all. Post-operative care is just as intensive and meticulous as the surgery itself. It involves careful serial exams, managing pain with multiple approaches, continued IV fluids, often broad-spectrum antibiotics, and even special care for the feet digital cryotherapy, basically icing the feet to help prevent laminitis, which is a serious potential complication after colic surgery. Feed is reintroduced very, very gradually.
What about recovery time and getting back to work?
The rehabilitation protocol is very structured. Typically, strict stall rest for the first month, maybe with some hand walking or grazing, then small paddock turnout in the second month, pasture turnout in the third, and then a gradual return to work over the next 1 to 2 months after that. It's a slow process. Ultimately, successful management nearly always requires a truly multimodal approach, combining all these medical, surgical, and supportive elements.
Okay, so a horse makes it through surgery or medical management. What's the outlook, the prognosis? You mentioned it varies a lot.
It really does vary significantly. Depends on the specific type of displacement, whether the blood supply was compromised, and crucially, how quickly treatment was initiated. But the good news is, long-term survival for horses with non-strangulating displacements is actually excellent, often better than 90%.
That's encouraging. What about the specific types?
For left dorsal displacement, prognosis is generally favorable, often resolves medically. As long as there wasn't a volvulus or significant damage, the outlook is good. Right dorsal displacement also has an excellent prognosis, especially with surgery. Survival rates over 90%. Large colon volvulus, the twist, that's much more guarded. Survival rates range widely, maybe 35% to 86%. Big range.
Huge range. Why so variable?
Depends heavily on how quickly they get to surgery and how much damage occurred. But with early referral and prompt surgery, those rates can climb higher, even over 85%. Postpartum mares, as we mentioned, are at higher risk, but specialized clinics near big breeding farms often report better outcomes because they can intervene so fast. Pelvic flexure impactions, usually a good prognosis, they typically respond well to medical management.
And overall for colic surgery?
Overall, general colic surgery survival rates have significantly improved, now typically between 74% and 95%. And interestingly, age alone doesn't seem to negatively affect recovery. Older horses without other major health issues tend to have similar survival rates to younger ones. Return to athletic performance is also pretty favorable. Somewhere between 63% and 85% of horses get back to their previous level of activity.
That's great news about older horses and performance.
It is. But this raises an incredibly important question, or rather, reinforces a point. The most powerful takeaway from all these statistics is crystal clear. Time is literally gut in these cases. Every single minute counts. The strong link between early diagnosis, prompt treatment, and a better prognosis just hammers home how time-sensitive this is, especially for those strangulating lesions. Getting veterinary help immediately is the horse's absolute best chance.
Okay, so time is critical. But even with successful surgery, the journey isn't always over, is it? Complications can happen.
That's right. Complications are definitely a possibility. Common issues include problems with the surgical incision itself. Infections happen in nearly a quarter of cases, maybe 23.7%, and incisional hernias develop in about 6% to 17%. Postoperative colic, or POC, is a big concern. Recurrence rates range from 20% to 50%. That means a horse is 1.7 to 7.6 times more likely to colic again after having colic surgery.
Wow, that much higher.
Yes. Postoperative reflux, POR, that fluid buildup in the stomach, can affect up to half of horses after small intestinal surgery. Less common with large colon, but still possible. Other potential pitfalls include laminitis, that dreaded foot problem diarrhea, and adhesions, which are like internal scar tissue. Adhesions are generally less common with large colon problems compared to small intestine issues, but they can still occur. And then there's the ongoing risk of endotoxemia, especially with strangulating lesions. That systemic inflammation can lead to cardiovascular shock, clotting problems, even multiple organ dysfunction.
So what's the practical takeaway for owners here? It sounds like you need to stay vigilant even after they come home.
Absolutely. Successful surgery is often not the end of the story. Ongoing management and vigilant owner observation and education are crucial because of these potential chronic issues, recurrent colic, adhesions, hernias. It really highlights the partnership between the owner and the veterinary team.
What about the chances of the displacement itself happening again? Recurrence.
The recurrence rates are significant and provide a really compelling argument for proactive measures in some cases. Overall, for any large colon malposition, the recurrence rate is around 10–15%, but for large colon volvulus, that twist. After just 2 episodes, the recurrence rate jumps dramatically to a staggering 80%.
80%. That's huge.
It's incredibly high.
Yeah.
Nephrosplenic entrapment recurrence ranges from 3% to 23%. And interestingly, horses that have one recurrence are even more likely to have another one. Plus, horses that have had right dorsal displacement seem more prone to recurrent episodes than those with other types. These persistently high recurrence rates, especially for volvulus and repeat offenders, provide a strong argument for considering those prophylactic surgical interventions we talked about.
Okay, that makes sense. So with all that risk and recurrence in mind, how do we try and prevent these conditions in the first place? What can horse owners actually do to minimize the risk?
Prevention is key, and it starts with good management. Dietary management is absolutely fundamental. Ensure your horse gets adequate long-stem fiber. That's crucial for gut health. Avoid sudden dietary changes. Any change should be gradual, over days or weeks, to allow the gut microbes to adapt. Sudden shifts can easily upset that delicate balance and lead to gas.
What about specific feeds, like alfalfa?
For horses prone to enteroliths, those gut stones, which can cause obstructions leading to displacements, restricting or even eliminating alfalfa is often recommended, as it's high in minerals that contribute to stone formation. Offering small, frequent meals mimics natural grazing patterns and is better for digestion than 1 or 2 large meals. Practices like hand grazing or using slow feeders, like sprinkling hay around, encourage natural chewing and slow down intake. And post-surgery, it's vital to avoid excessive bulk initially. Often, fresh grass is preferred over hay as the gut heals, as it's easier to digest.
Makes sense. What about non-dietary management?
Management practices are equally critical. Regular dental care we mentioned, essential. It directly addresses that link between poor chewing and impactions. Can't stress that enough.
Checks those teeth.
Absolutely. Adequate water intake is non-negotiable. Dehydration is a major risk factor for impactions. Always have fresh, clean water available. Minimize any management practices that might mess with normal colonic activity or produce excess gas. Think about stress, changes in routine. Limit prolonged stall confinement. Horses are designed to move. Encourage appropriate daily exercise or turnout for normal GI motility. And back to that point about rolling, if your horse shows signs of even mild colic, try to prevent them from rolling violently. Hand walk them, keep them calm, call the vet. Uncontrolled rolling can definitely make things worse.
Right. And then there are those preventative surgeries we touched on.
Yes. And if we connect this to the bigger picture, these procedures represent a really sophisticated understanding of disease patterns and a proactive approach to managing equine health, especially for high-risk individuals. Nephrosplenic space ablation, for example, surgically closing off that space between the kidney and spleen to prevent future entrapment there. It can even be done standing, laparoscopically, reducing risks. It significantly reduces the risk of that specific displacement, though other types could still occur.
What about the colipexy, tacking the colon?
Colipexy, surgically attaching a part of the large colon to the body wall, aims to minimize volvulus and prevent other displacements. However, it's not routinely recommended for every horse. It can have complications like affecting colon function or causing chronic pain, so it's usually reserved for specific cases with high recurrence risk. And finally, colon resection, removing part of the colon. This might be considered for recurrent large colon volvulus, especially in valuable broodmares, because of that incredibly high 80% recurrence rate after 2 episodes. But again, it's a major procedure, carries significant risks, and isn't routinely recommended.
So those are options for specific high-risk cases, not general prevention.
Exactly. Prevention for most horses relies on that holistic strategy. Excellent diet, water, dental care, exercise, and management.
Okay. So today we've really taken a deep dive into the incredible complexity of the horse's gut, haven't we? We've explored the diverse types of large colon displacements, the crucial role of early accurate diagnosis using multiple tools, and the evolving treatments from conservative care right through to advanced surgery.
And it truly reinforces the profound importance of that holistic approach to equine health. From routine dental checks to careful diet changes and daily management, seemingly small details can have absolutely major impacts on these critical internal systems. It really proves how much preventative measures matter. They can literally be life-saving.
So what does this all mean for you, the listener? Well, it means understanding the horse's intricate internal world helps us appreciate the constant advancements in veterinary medicine. The ability of a horse to recover from such profound internal disruptions is truly remarkable. It reflects both their incredible resilience and, frankly, the dedication and skill of modern veterinary science. What stands out to you from all this?